And with that, I would like Dr. Tarantillo to introduce our next guest, Dr. Eric Sherman.
Hi, thank you. It's my pleasure to introduce Dr. Sherman. He's a professor of medicine at Memorial Sloan Kettering in the head and neck oncology section. He's an international expert in thyroid cancers and oral cancers. He's involved with multiple international research projects. He's on the steering committee of the Radiation Therapy Oncology section. It's a pleasure to welcome him back, and thank you for coming.
Hi, everyone. It's definitely a pleasure to be back. Let me share my screen. Good. I hope everyone can see this. Okay. So I'm going to talk about the review of head and neck cancers at ASCO this past year. And I got to say, it was really great to actually see people live again. And it was definitely a good meeting altogether. Sorry. There we go. These are my disclosures. The outline I'm going to talk about today is I'm actually, a lot of the stuff that came from the oral session was actually nasopharynx cancer. So, and a lot of it involving chemotherapy and radiation therapy. So I have several studies I'm going to talk about that. Head and neck squamous cell carcinoma, both in chemoradiation arena as well as in metastatic disease. And then I'm going to mention one study in thyroid cancer that I actually thought was very interesting in terms of how we manage these patients. So let's first start with nasopharynx cancer. The first study I'm going to talk about is a randomized phase 3 study comparing with everyone getting chemotherapy and radiation therapy for locally advanced nasopharynx cancer plus or minus nemotuzumab, and I hope I can getting close to pronouncing that correctly. Nemotuzumab is a humanized IgG1 monoclonal antibody against the extracellular domain of EGFR. It's supposed to be devoid of a lot of the class-specific side effects of EGFR inhibitors, but in a lot of ways, the way I think of this is a cetuximab drug. It is not approved in the United States, but approved overseas. And actually, the prior year, a group from India actually presented a study of this with chemoradiation in head and neck squamous cell carcinoma. This was a pretty straightforward phase 3 study. Patients with stage 4 nasopharynx cancer were randomized to receive standard chemotherapy and radiation. So that's either IMRT or 3D conformal radiation therapy. So it could be either one. They received the radiation therapy for 6 to 8 weeks. They all got cisplatin 100 milligrams per meter square every 3 weeks. And then either got placebo or nemotuzumab. The thing that should come out that you to consider with this is that the standard of care for nasopharynx cancer at this point in time in this population is either to give neoadjuvant chemotherapy or adjuvant chemotherapy, and that was not part of this study. The primary endpoint of this is 5-year overall survival. And these are the results. And when you look at these curves, the overall survival curves, it favors the addition of nemotuzumab. So the addition of this monoclonal antibody to the current chemotherapy and radiation therapy is shown to have a survival benefit. And this is a survival benefit that I think in most cases, everyone will be very, very happy with. And I think a lot of times we even consider this as something to maybe even change standard of care with a fairly good follow-up in these patients. There are a big caveat with this. The first one is about when you look at the group with IMRT versus CRT, especially in the United States, IMRT has really become standard of care in nasopharynx cancer. 3D conformal radiation is not the easiest to give. There are a lot of advantages to IMRT. And when we consider the IMRT group, there's a real question whether nemotuzumab has almost any benefit in that population. The real benefit is using older form of radiation therapy that may not be as good. And that should first bring up the first question is the benefit here something that really translates to our population? Because almost no one gives 3D conformal radiation in the US anymore. From that, even IMRT, a lot of us have changed to proton therapy. And you could argue whether proton therapy is any better than IMRT, but one of those are more the standard, and you really don't see that additional benefit in that population. So it could be that this is just adding more intense treatment when the backbone of the therapy is not as good. So when you include with this, sorry, here we go. The addition of nemolizumab and EGFR inhibitor improves outcomes when added to cisplatin and radiation therapy for nasopharynx cancer, based on this study. The problem is one, EGFR inhibition has not had impressive results in nasopharynx cancer. So while cetuximab is part of the NCCN guidelines as a compendium-approved drug, I'm really making it back in the era when we had nothing really good in nasopharynx cancer, and a lot of us really don't believe it has almost any activity. I can tell you, I personally have not used cetuximab in nasopharynx cancer probably for now maybe 15 to close to 20 years. Most of us don't do it, so it's sort of strange this EGFR inhibition would lead to any type of benefit in nasopharynx cancer. And in more typical head and neck squamous cell carcinoma, where there's no question, at least that cetuximab has more activity, we have not seen benefit with the addition to chemotherapy radiation therapy. And the base of this is RTOG 0522. So this is a large, well-published study where people got almost the exact same thing of cisplatin radiation plus or minus, in this case, cetuximab. And there's absolutely no benefit adding cetuximab to cisplatin. And there is even maybe some suggestions of it being worse. So it's hard to believe that in nasopharynx cancer, this addition of an EGFR inhibitor to chemoradiation is really a true overall survival benefit. I don't think this is going to change anything what we do in the US, just so you know. I'm not even sure it's going to change anything that they do in China with it, because it's not a study that makes a lot of sense in the first place, and you do sort of really wonder about that issue with IMRT not having any benefit. The next few studies really are looking more at trying to decrease treatment intensity in nasopharynx cancer, with the idea that nasopharynx cancers in general do fairly well. They are responsive to chemo and radiation, and maybe we don't have to be have as high intensity of treatment and maybe decrease toxicity. So one study was looking at this question of, can we do radiation therapy alone versus concurrent chemoradiation in low-risk nasopharynx cancer? And this is supposedly a non-inferiority open-label phase 3 study done in China. Their definition of low risk was either a T1N1 or T2N0N1 tumor. They also allowed T3N0 nasopharynx cancers. They excluded those patients that they thought were at a higher risk. So if you had a lymph node greater than 3 centimeters, like a level 4, level 5, so like a low level cervical lymph node, you can see extranodal or extracapsular extension on scans. If you had high EBV DNA at baseline, those people were excluded from this type of study. And patients were either randomized to receive IMRT alone, so just radiation, nothing else, and this is IMRT, or IMRT with concurrent cisplatin. Primary endpoint, failure-free survival. In a disease that's very curable, and no data that I know of that shows failure-free survival is a great surrogate for overall survival. So it's not like, colon cancer where there's no question that's present. I'm not sure this is the best outcome you would want to do if you're trying to de-intensify treatment. At least in a phase 3 study. A phase 2 study would have been different. And then when you look at what they actually looked at for margins, they actually, I don't know if you can see, is that they're looking at a 10% difference That's a large difference for survival, or for failure-free survival, but a large difference to actually try to see. And when you look at the number of patients they had in the study, it's only 338. When you think of a non-inferiority study, you really think you want a large study. If you're going to detoxify treatment, you want to make sure that detoxification will not affect survival. And the 10% difference, low number of people, this is something I think we all need to be concerned about. And you have to remember, this isn't like, it's one thing to do this in a disease that's rare, but this is a study being done in a country where there are hospitals that see 1,000 nasopharynx cancer patients per year. So have to do this in such a low number of people when it was very easy to do a much higher number, I think also is very concerning. When you look at this, the endpoints, you see that what they describe as no difference in failure-free survival between the two different arms. But failure-free survival, you can see that the chemotherapy radiotherapy group is higher. And the percentage difference is very small, but it is higher than what you see in the IMRT alone arm. And that's same thing with overall survival. You see that it is larger. So you're taking a very large, you're asking for a very large difference in a non-inferiority study. And you see that standard more intense arm is above your less intense arm. So thinking that the less intense arm is better is a concern. The other thing you have to always think about is, how does this even translate to like the US population? Is the population in China the same as what we see in the United States? And it's difficult to always tell for sure, because in the US, it's hard to run these studies because we don't have the same number of nasopharynx patients. But RTOG 025, it was a study done looking at IMRT in nasopharynx cancer done by the cooperative group system. And when you look at this, the one thing you do see, and this is a higher stage group, so I'm never sure exactly if this is a really great translation or a great representation of the US versus China population, but you see a much lower survival rates going on and much higher progression-free survival. And the reason why I bring this up as a very big concern is that either we're saying that in the US, people are getting worse care using the exact same treatment, which is very difficult to believe, or there's something that these are not matching up like we would think so, and there may be a translation issue from China to US to where it may not be appropriate to take this management and translate it to our own guidelines. So in conclusion, the author's conclusion is that IMRT alone is now reasonable in low-risk nasopharynx cancer. I got to tell you, if I was a patient right now, I want chemotherapy. The chemotherapy arm looks a little bit better. A 100% survival rate in someone getting chemo radiation, one, is great, and alone will want me to get chemo, but that looks a lot higher than what we see in our population. So I'm not sure this data translates as well in the US as it does in Southeast Asia. And this is a really small non-inferiority study that's asking for a really large difference in failure-free survival, not even overall survival. So this is not a study that I would ever feel comfortable decreasing treatment intensity with the belief that I'm going to lead to the same outcomes. So I do have a lot of trouble with this study, and I'm not sure like this is going to lead to any changes in the US, but you never know. And the last thing I say is that the curves all favor chemoradiation. So like I said, if the curves all favor the IMRT arm, then, with everything I said, maybe you can still say, everything looks in that group, maybe, everything's okay still to go with IMRT alone. That's not the case. The curves have the CRT a little bit higher. The next thing is a very interesting study of reduced dose radiotherapy for pretreatment EBV DNA selected low risk nasopharynx carcinoma. So this is sort of the same idea that there's this good risk population that you can now decrease dose intensity. This is a phase 2 study and it's a single arm, so it's not randomized. And they do a lot of things that we've been doing in the United States in HPV tumors. The first thing is they choose what they think is the low risk population, low EBV DNA, stage 3. They then give them induction chemotherapy with the idea that tumors that respond very well to induction chemotherapy will respond very well to chemoradiation. And this is a whole long history in head and neck squamous cell carcinomas, going back to really the VA study, where in larynx preservation, they use induction chemotherapy to predict who would do well with radiation and who should go ahead and have surgery done. Probably something that should be looked at further again, but still, it's a very reasonable thing. So if you got induction chemotherapy, you had a complete or partial response and undetectable EBV DNA, which is supposed to be very predictive. You then went down and got 60 gray instead of 70 gray. The one thing to note is the chemotherapy was the exact same. It's 3 cycles of cisplatin. It just, that part did not change no matter which cohort you're in. When they did this, a little bit more than half the patients were able to get 60 gray, a little bit less got 70 gray. So it wasn't something that this made a difference in 90% of the population. At the same time, it also didn't make a difference in only 10%. It was about a 50-50 split in this. And what they showed was really some really truly excellent survival in both groups. But the 60 gray cohort, which looks like they had very good progression-free survival, excellent overall survival. And when you look at the 70 gray cohort, it looks like it was doing as well, if not better. Now, remember, this is not a randomized study. You can't compare the 60 gray to 70 gray. The reason you can't is that 70 gray was this population that did not respond to chemotherapy, induction chemotherapy, had either elevated EBV or something else. So this is already a poor prognostic group. So the fact that they have a worse PFS, I would not say I would say that's almost expected, but it gives an idea that this may be a way to cut down radiation. The next question you should always have is like, really, who cares? I mean, when I say that is, it's a savings of 10 gray. You're not cutting down from 70 gray to 30 gray. You're cutting down from 70 gray to 60 gray. Does that make a difference to patients? I mean, the treatment will be done a little bit sooner. How much sooner? Probably like a week sooner. So you're not saving a long time from the treatment. Well, so they looked at long-term toxicities, and I think this, acute toxicities to me is not as usually as a big a deal. When you really look at patients' preferences, they are willing to go through a lot of acute toxicity if it leads to better survival. But long-term toxicity is a little bit different. And interesting, in the 60 grade cohort, they had no long-term late grade 3 or 4 toxicities. Considering there are 3 cycles of cisplatin, it's hard for me to believe that how real this really is, to be perfectly honest. But it looks good. But even in the 70 grade cohort, they didn't have a whole gang of late toxicities. And I do sort of wonder if things were missed in both groups with it. But I think this is an interesting concept in terms of something to investigate further into ways that we may be able to decrease radiation intensity, and by doing so, long-term toxicity in this nasopharynx population. So basically, standard chemotherapy radiation has significant acute and long-term toxicities. And this is, like I said, this is what we're doing in HPV positive disease right now. So I think good studies to evaluate ways to decrease treatment intensity in select populations should be done. The question is how to do it. And, should this all be done in Southeast Asia, where this is a large number of, where the largest number of patients are? They can do these studies very, very easy and very quickly. But how this translates into the US population, I think, is a big question. So in terms of all these studies, I think these are interesting studies that were presented at ASCO. It is that all these studies were done in China. These are not studies that were done in the United States or Canada. And, if we do studies in the US, they need to be repeated in other countries to show that the populations are similar to it. And I'm not really sure any of these are going to practice change in the US. So even though you have some positive studies, adding EGFR inhibitor, cutting down or getting rid of chemotherapy in certain circumstances, I'm not confident enough with the data at this point that this is going to be something I would do. And I think this is really the big question, is that when we decide on treatment decisions and guidelines in the US, how much are we going to take into account studies done in other countries? Or do we need to figure out a way to do this in the US, even though these are rare cancers? And I'll say, like, things about radiation and chemotherapy is that this is something that the individual clinician needs to make the decision. NCCN also has to make that decision when they make the guidelines, but the FDA is not making these decisions. When a lot of these studies are being done where the FDA is making decisions, they do question the quality of the data from some of these other countries, and that has to be in our minds when we're trying to make a decision on how to change our own practice. So let's talk about head and neck cancer chemo-RT. This is a published study done called Javelin, and this was a very long awaited study to get these results. This was a randomized study of cisplatin radiation plus or minus avelumab, a PD-L1 inhibitor. Patients got this both concurrently with radiation and then followed with adjuvant therapy. And with everyone loving immunotherapy, we thought this was going to be a guaranteed winner that was going to change practice. There was no early data done for this study. They went right to it. And when you look at the results, what you see is that the group that got immunotherapy did worse than the group that got chemoradiation. This was a shocker. I mean, not even equal. I mean, this is really, like, they did worse. And the question is, why did this group do worse with it? And it's gotten to the point that with multiple studies using immunotherapy with radiation in head and neck cancers are not coming back positive. If anything, they're coming back worse than chemo and radiation. So we're getting very disappointing results altogether. So what David Klump and his group did was actually do something that really we should have done before we did so many phase 3 studies in the United States. And they looked at the question of concurrent versus sequential immunotherapy or pembrolizumab in combination with cisplatin and radiation. So this is basically it, is one arm got chemoradiation and then got immunotherapy. So immunotherapy was done after this treatment. The other group is doing, the other arm is doing what we've been doing in all these other phase 3 studies, is we start with immunotherapy. We start like a week before they get chemoradiation. We give them chemoradiation and continue immunotherapy, and then continue immunotherapy for a little bit of time afterwards. And he said, okay, let's look at these two things and see what's better. And what these showed is that the sequential arm, the group that got immunotherapy adjuvant, but not concurrently with radiation, that arm looks better. Do we know for sure it's better? No. This is a phase 2 study. It's not gigantic. You can't tell for sure about with it, but this is sort of the first study that really should have been done, because if you saw these results, every single big randomized phase 3 study would have probably not said, forget concurrent chemoradiation and immunotherapy, let's do the immunotherapy afterwards. And and this is why sometimes rushing to do a big phase 3 study is the wrong thing to do before you get the data set up on how to do it appropriately. Because it really sort of suggests that all these studies we did, and I got to tell you, there are not only a lot of phase 3 studies that have been completed. There are phase 3 studies that are still going on, and they're all adding immunotherapy at the same time as chemoradiation. And this really suggests that's not the right approach with it. So, I think in a lot of ways, this is an important study in that sense. Now, does adjuvant immunotherapy really lead to a benefit? Well, I still think that's a study question, but it does suggest what we're doing may be the wrong thing. And I'm sorry, I should have showed this too, that the overall survival is the exact same thing. Sequential looks a lot better than concurrent. So I think all these future studies really need to focus on this observation, and it does really emphasize that sometimes there is a reason not to rush to do a study. We all said, there always the feeling is, we have patients with cancer, we need to get the best treatment to them as soon as possible. But phase 3 studies are something where we're putting a lot of patients on treatment that we're making assumptions without the real data to support those assumptions. And they're costly studies. By doing those studies, we're not doing other studies that are important. And even worse, a lot of times we are doing 10, 15 of the exact same studies. So it's unbelievable how many concurrent immunotherapy, radiation therapy studies with or without chemo are being done in head and neck cancer or have been done. And this really suggests that all those studies were done incorrectly. The next thing is this results of this phase 3 randomized study of docetaxel in patients with head and neck cancer unsuitable for cisplatin-based chemoradiation. And I gotta say, if everything will be presented today, this is probably the closest to something that may be considered a change of practice. So there's no question in everyone's mind, cisplatin with radiation therapy is the standard of care. It never should be a question. The problem is cisplatin is a tough drug, and there are a lot of reasons why people cannot get cisplatin. In a lot of places, the argument is that radiation therapy should be the standard treatment. And a lot of people will say, that's ridiculous. We know that cisplatin radiation is better than radiation alone. It makes sense that other types of chemotherapy would also lead to that same benefit. This is one of the really first studies that has really looked at this question in those patients who are cisplatin unsuitable. People are randomized to receive either docetaxel and radiation or radiation therapy alone. In their definition of cisplatin ineligible, they have a lot of things that make sense. There actually has been prior studies to show that ECOG performance status of 2, that there really is that chemoradiation probably, or cisplatin radiation, does not really lead to any type of benefit over anything else. If they have hearing loss, tinnitus, neurologic disorder, we don't give them cisplatin. Bad kidney function, we don't give them cisplatin. People with comorbidities that will preclude the use of cisplatin are definitely present. So a lot of these are things that I think are there. The concomitant use of nephrotoxic drugs required for a concurrent condition, I think, is a little bit more of a borderline call with it. But when you look at what things that they use, in general, most of the stuff is reasonable. For the life of me, I can't figure out why diabetes, hypertension, or pulmonary TB would have me not give a person cisplatin, but would let me give a person docetaxel. But they included those as part of the eligibility. But when you look at these survival curves, you see that the addition of docetaxel to radiation leads to an overall survival benefit compared to radiation therapy alone. And this definitely fits in the p-value of less than 0.05. So the conclusion with this is that if someone's not cisplatin eligible, I think the belief that people had in the past that they should get radiation therapy alone, which a lot of us don't believe, I think should be now gone. This docetaxel of 15 milligrams per meter square is very easy to give. Many of us have been doing this as one of the options for many years. And I think now we sort of have definite proof that, it leads to a benefit. Do you always have to do docetaxel? I think people a clinical trial, it's a question how pure you want to be about this or not. But at the same time, I think it does push the idea that just because we can't give cisplatin, there are other, probably radiation therapy alone is rarely the right answer unless you're really in a situation where you can't give chemo one bit. The next thing is it was a phase 3 study of weekly versus every 3 weeks cisplatin. And there's been multiple of these studies going on to try to show that weekly is as good as every 3 weeks or high dose cisplatin. And a lot of this has to do with this belief that weekly cisplatin is easier to do than every 3 weeks. The group that looked at this is a group in India, and it's interesting because in India, they did a similar study, but they used cisplatin only at 30 milligrams per meter square and showed that a high dose was every 3 weeks was superior. This time, they decided to really look at the 40 milligrams per meter square, which is more common dose. It's another study where they looked at a non-inferiority margin of 10%. And like I said, when you're really looking at curative treatment, a non-inferiority margin of 10% probably is not appropriate. And, it got them to do a study that only required 130 evaluable patients in each arm. So it's another small non-inferiority study. But these small non-inferiority studies, there's a point that, if you're not going to do it correctly, it probably shouldn't be done. When this was looked at in RTOG with cisplatin radiation versus tuximab radiation, that study went to 1,000 patients. And that's how you do these studies appropriately. You do a large number to really see if there's like a difference or not a difference. And unfortunately, like I said, that's not, I think what ends up happening. So radiation was similar in both arms. You're allowed to use 2 conventional or IMRT. Chemo was either 100 or 40. And when you looked at the survival for each one, you can see in the standard arm, so every 3 weeks, it's 30 months for median progression-free overall survival, 25.5 in the test arm. They say there's no difference between the two, but it's the same thing. The curves favor the group that get every 3 weeks, but their conclusion is there's no difference. When you look at the curves, they are pretty close together, but like I said, these are not the statistics or the numbers that I would ever be very happy with. This is the other problem, though, so this study was done during COVID, and when you look at the number of people dead, it's over 50% of people are dead, with another 16% alive with disease. This is like really bad data. I mean, really, sorry, not bad data. I'm sorry. This is a really bad outcomes. We don't get outcomes like this awful in head and neck cancer normally. And when you look why people died, I mean, they had people dying from tuberculosis. They had people dying from COVID, promptly suicide. And when they presented the data, one of the things that was brought out was that there probably wasn't as much of compliance. There's a lot of issues in terms of treatment breaks secondary because of during COVID that things just couldn't be done as they normally can. So this is not like the general population that we would normally end up treating. So to me, non-inferiority studies really need an appropriate number of subjects. And I gotta say, like these studies of 200-300 people, it's really, to me, sort of ridiculous. You're trying to show not something is better, but you're trying to show something's not worse than a standard treatment. And you're doing this with a small number of population, allowing for a pretty big difference in outcomes. And I gotta tell you, that's probably the most inappropriate way to be doing these type of studies. And And this really should be, I think, a better quality check when these studies are presented. And I think you also need to be very careful when we're doing reporting studies during COVID. I think this is going to happen more and more often. Not just this study, but I think most studies, is that when you need to, like, radiation therapy, you can't get radiation breaks. If you get radiation breaks, you're having worse outcomes, and that changes everything. So I think as we get more of these studies reported of things during COVID, we need to be very careful on how we interpret these results. So let's talk about metastatic head and neck cancer. These are very simple. This is a lot easier than what I've done before, or I've talked about before. This is a phase 2 study of pembro and cabozantinib. It's very straightforward. Pembrolizumab is sort of often the standard if the CPS score is greater than 0. This allows CPS score 0, and about 6 to 10% people have CPS of 0. They added cabozantinib, that's the VEGF TKI with it. So the idea of using VEGF TKIs with PD-1 is something we're doing in a lot of cancers. And the results from this are really great. I mean, 54% partial response is so much higher than we see with PD-1 by itself. And there's no data that drugs like cabozantinib have any activity in head and neck squamous cell carcinoma, or if they do, it's very, very minimal. So we're seeing high PR rates, high standard or stable disease. And when you look at the progression-free survival, it's 14.6 months. I mean, this, and a 54% 1-year survival, this is as good as we're seeing with any other immunotherapy combination. Now, the big problem with these type of studies is toxicity. And overall survival is even better. I mean, this is like amazing median overall survival, like really amazing. So the big thing has always been toxicity, but the toxicity that they're reporting, and they use a low dose of cabozantinib, was really quite small. I mean, not many grade 3, 4 events were going on. So these are things, and these are things that are easy to often take care of. Hypertension, ALT/AST increases, oral mucositis. These are things that are not that lipase increases, not anything that would like panic me about it. I mean, usually you expect some really bad side effects from the VEGF TKIs, and we're not seeing that with this regimen. So this is really something that is really quite impressive. Toxicity is really surprisingly low, and it really needs to be further evaluated. So I bring this up as not like a change of practice, but as something that really may change practice in the future. Because like I say, this was one of the more impressive results I've seen in the metastatic setting. And this is a nice multi-institutional study being done in the US. This other one is this phase 3 randomized study evaluating the role of low-dose Nivo to palliative chemotherapy in head and neck cancer. And I got to tell you, like, this was a poster and part of the poster discussion session. And there was a lot of questions that came out from this, and questions were not bad questions. I mean, these were comments going like people were really excited about this. So this is a phase 3 study where patients received, and I'm sure if you look at the bottom, they received methotrexate 15 milligrams per meter square PO weekly, Celebrex 200 milligrams daily, or erlotinib 150 milligrams daily. So this is an oral regimen of drugs that have been around, almost longer than I've been practicing for the most part, along with an intravenous dose of Nivo of 20 milligrams, not 20 milligrams per meter square or anything like that. This is a flat dose, 20 milligrams every 3 weeks of Nivo. So much lower than we normally use. And you can see that when the group that got that little bit of low dose Nivo, they did great. I mean, this is not progression-free survival. This is overall survival, and overall survival of 43% at 1 year. That is so impressive. Response rates going from 50% to 65%. So really great overall survival, pretty good progression-free survival that we're seeing. And look at the cost. So for them to do methotrexate, celecoxib, and erlotinib, it costs them $26 a month. So think of that compared to what we normally do in the United States. To add Nivo, yes, that costs a lot. That's $429. If you use Nivo at normal doses, it's close to $4,000. Pembro is $5,000. So here you're using much cheaper drugs, and you're getting great results. So this is really things I think that we should be thinking about. And it was really brought up that the dosing we use of immunotherapy is much higher than the vast majority of people need. There's probably a small population that have antibodies to these antibodies that need a higher dose. But I don't think and it's someone said maybe you should be testing those antibodies ahead of time so you should get low dose. But I don't think you need to for something like this. I mean, this is something where the results are so good, that's what we should just take out of it. It's great results, cost a lot less money. And can you imagine, considering how much money we're using for immunotherapy in so many, not just head and neck cancer, but other cancers, how much we could probably save? And it, like I said, everyone was just looking at this going, wow, we might not do anything because of insurance, but we might be able to get away with a much lower dose of immunotherapy. And even the chemotherapy regimen, that's a nice chemotherapy regimen. If it's costing someone $26 a month to do chemo, that's all through the mouth. I mean, forget the Nivo part about it. That's pretty impressive. And the calcoxib will also probably help any arthritis that they have at the same time. The last thing I'm going to talk about is thyroid cancer. So I am almost done. This is also going to be quick. There's a study called Cosmic 311. This is a randomized phase 3 study. It's already been completed. It was looking at cabozantinib versus placebo in RA refractory thyroid cancer. All these people had prior VEGF TKIs, up to 2 prior lines of treatment. And this showed a PFS benefit. This was basically showed that you could use cabozantinib in the second line compared to placebo. It was a very low bar to get by. It got by that low bar. Not everything always does. FDA approves cabo as the second line. But, this is a very valuable study because of all the other information that's part of it. And the thing that was always a question is that, how, does the other VEGF TKI make a difference? So what they did was this subset analysis of the study. And they had 2 posters of it, both of them interesting, but this one specifically I was interested in. So the 2 FDA approved drugs for RAI refractory thyroid cancer is lenvatinib or sorafenib. And most of us are very confident lenvatinib has much higher response rates. It has a much higher progression-free survival. And if you go to the the NCCN guidelines, they basically tell you, go use lenvatinib. The thing about lenvatinib is that in their randomized phase 3 study, when they allow lenvatinib both in the first and second line, and in the second line, the median progression-free survival is about 3 months less than it is in the first line. So not a gigantic difference. What you see here is that in the group that got prior sorafenib, the median progression-free survival for cabozantinib is over 16 months. Really quite good. In fact, actually, that's as good as you get in the second line with lenvatinib. So really great, really impressive results there. However, if a patient was on lenvatinib previously and now went on to cabozantinib, the median progression-free survival was only 5.8 months. So one of the things that this brings up is that maybe from sequencing of treatment for thyroid cancer, lenvatinib probably should not be our first thing. Treatment after lenvatinib it does a lot worse than treatment before lenvatinib. And if lenvatinib has similar data in the first and second line, and at least from their published data in New England Journal of Medicine, from their phase 3 randomized study of SELECT, it looks not that much different in the first or second line. Second line looking just a little worse. but big differences in terms of other drugs after lenvatinib. Maybe doing another drug first and using lenvatinib in the second line is the better thing. That if you're trying to sequence, this might be the approach. So I think this is one of the things that we have to be thinking about, and there probably should start becoming more studies in thyroid cancer, really trying to answer the sequencing of treatment effect. Because, you know, there's a lot of people in thyroid cancer that we go from one drug to another drug to another drug, and how we choose which drug to use first has not been really well studied. And this probably should be the next question, although it's a question that may be very difficult to answer because of support of the study. So for my final remarks, is there any game-changing studies at ASCO this year? Well,
No.
I hate to say this, but no. Yeah, there's nothing here that I think that changes that or anything. I think there are interesting studies. I think one of the big questions is studies in other countries. Do they really reflect the North American population? Are there issues with quality control and that need to be evaluated before we make changes in our practice or guidelines? Yes. So these are things we do need to sort of figure out a lot more about. But while there may be some interesting studies to be thinking about for future studies, there's nothing I think that came out that really changes my practice, with maybe the closest one being the docetaxel with radiation. I think more clarifies that probably radiation alone should not be used in cisplatin ineligible patients if you could use chemotherapy with it. So in terms of the questions that were asked, I'm not sure if everyone's answered them before or not, or how I was supposed to present this. But the first one is in a patient with significant hearing loss, what would be the most reasonable option to use concurrently with radiation therapy for a T4N1 P16 negative squamous cell carcinoma of the tonsil? So I put in 4 things. Which one would be the answer? I think from this, you should pick C, docetaxel. After treatment with concurrent cisplatin radiation therapy for a T2N2C M0 squamous cell carcinoma of the larynx, what adjuvant therapy would be standard at this time? And I think, you know, based on this, it's still surveillance alone. So even though we have that pembrolizumab data of sequential looking very impressive, that does not change practice, but that should be the study that we should look at. And there are studies being done with immunotherapy in the adjuvant setting. And it'll be interesting to see what those results are. But it does, like I said, again, emphasize that, you know, we should have been doing, this is probably the first study that should have been done, not everything else that we had done. And the last one is the combination of cabozantinib and pembrolizumab in the metastatic setting of head and neck cancer is what? Standard care? Is it too toxic to consider treatment as a treatment option? Has a 30% response rate in the phase 2 study, or a median PFS of 14.6 months. And then answer for this is D. I mean, it's not standard of care, but this is not, at least from the data that was presented, this does not look that toxic. And this really looks really promising. And the median progression-free survival of 14.6 months basically is better than what most of our studies show for overall survival median overall survival. So this is really an unbelievably promising regimen that I'm hoping gets looked at in a randomized phase 3. So I'm not sure if you want to say any questions, but thank you very much.
Thank you very much, Dr. Sherman, for that presentation. And I'd like to open it up for any questions. Feel free to unmute yourselves or type those up in the chat box. All right, Dr. Sherman, I'm not seeing any questions or hearing any questions, so definitely appreciate your time with us. Thank you for spending your Saturday and sharing all this valuable information.
Thank you very much. It really was a pleasure being here.
All right, thank you. Have a great day, sir. All right, I just want to thank everyone for your participation today. We've reached the end of our event. And I hope that you've enjoyed your time with us, that you've learned something or heard something new. As a reminder, I'll be sending the evaluation link to our attendees in order to claim your continuing education credit. And I also want to definitely thank our speakers for sharing their time and expertise with us, and thank our sponsors for supporting today's programming. I also hope that you'll be able to join us during our monthly evening speaker series events. Our next event is going to be on August 2nd, and the topic will be neuro-oncology. So hope that you'll be able to join us for that as well. And with that, enjoy the rest of your Saturday. I let you out 9 minutes earlier, so thank you guys for sticking around.